Afternoon, everyone, and welcome to More Doctors Where They're Needed, a conversation on reforming Medicare's GME formula. My name is Kai Gubbs. I'm the Government Affairs Manager for the Niskanen Center's healthcare team. We are very excited to have this conversation today. I am joined with our senior analyst, Lawson Mansell, and David Schwartzman, co-writers of today's paper in which they will be presenting. I will first introduce everyone, and then we will turn it over to our distinguished panelists to begin the conversation. First things first, Lawson Mansell is a senior health policy analyst who works on ways to improve the supply and affordable healthcare. Prior to joining Niskanen, he was a research associate at the Milken Institute in Santa Monica, California, where he authored reports on regional workforce trends and health disparities. Mansell previously had worked on education and healthcare policy issues in his home state of South Carolina, where he also served on the staff of South Carolina's first congressional district. His analysis has appeared in The Hill, The Argument, The Philadelphia Inquirer, and other publications. Mansell completed the Health Reformers Academy Fellowship in 2023. He earned a master's degree in public policy from Pepperdine University School of Public Policy, and has a bachelor's degree in political science from Thomas Edison State University. David Schwartzman is a health economist with experience researching, advising on federal payment policy and healthcare delivery reform. He served as an economist at the Center for Medicare and Medicaid Innovation, where he advised on accountable care organization model development, and led financial policy for ACO REACH, a $37 billion annual payment model serving 2.4 million Medicare beneficiaries. His research has examined the impact of employer-based and government alternative payment models and of regulatory frameworks for healthcare supply. Schwartzman earned a doctorate in economics from Washington University in St. Louis and a bachelor's degree from Hillsdale College in economics and applied mathematics. Thank you all so much for joining us today. My name again is Kai Gubbs, and I am happy to turn it over to my distinguished colleagues here. Lawson, David, it's great to have you. Please take it over.
Great. Thank you, Kai, and thanks for everyone for joining. Look forward to this conversation. As Kai mentioned, David and I have been working on this paper for the last few months, thinking through some of the difficult questions surrounding the doctor shortage and how Congress can actually make a meaningful impact on improving access to care in rural communities and in specialties facing acute shortages like primary care and psychiatry. Just to get started today, wanted to kind of answer one of the key questions, I think, because I know we have folks in the room who may be super familiar with this and other folks who may not be. What is Medicare GME? So GME stands for Graduate Medical Education, which is essentially the training that occurs after a prospective doctor earns their MD in medical school. Following medical school, in order to get licensed to practice medicine, all of these doctors must go through a residency program. Those residency programs can vary from 2 to 4 to even longer years in length. What happened is in 1965, when Medicare started, the idea was initially intended to be a way to reimburse teaching hospitals for the costs of training residents. I mentioned here that Medicare GME funding, which is now around $21 billion annually, is really a historical accident. That is that initially, the idea behind funding teaching hospitals and reimbursing them for the cost of training residents was simply to acknowledge the fact that if Medicare patients were going to get care at these teaching hospitals, then they should help cover the bill and any of the costs associated with training those residents. But over time, as the program ballooned over the next 20 to 30 years, it's now turned into a massive pot of money that has real implications for shaping the physician workforce and where folks train. Right now, it's distributed to roughly over 1,000 teaching hospitals nationwide and funding over 100,000 residency slots. And it's currently the primary way the federal government subsidizes the physician pipeline. I wanted to kind of step back a little bit before we get into some of the nitty-gritty of our paper and talk about the overarching takeaways that David and I found. The first, I think, key thing to realize about this pot of money is that the formula hasn't been meaningfully updated in nearly 40 years. When it was initially created, there were concerns in the 80s and 90s about potentially spending too much on an open-ended pool of funding that was going to residency programs. And so in 1997, the funding was capped at a per institution level. But ever since the inception of the program, there hasn't been any meaningful change to the way the formula is calculated. That has been relatively set in stone and then essentially frozen in 1997 when the cap was in place. We argue in this paper that the way the funding is set up, the way the formula is designed, is it systematically disadvantages rural and small programs by essentially funding more money to legacy institutions that had a large amount of residents at the time that Medicare was established, and then at the time the cap was instituted. It depresses primary care training by allowing teaching hospitals to get more money based on the amount of residents they have, plus how expensive procedures are. And then third, it locks in outdated geographic distribution. That is, and we'll show you this later in the presentation, that the funding tends to flow towards institutions in the Northeast and does not meaningfully impact the doctor shortage in areas in the Southeast, West, and Midwest. Our last argument in the piece is that any fix, any reform to how Medicare GME is run shouldn't just be focused on more slots, but rather fixing the formula to actually reorient dollars toward need. We argue that the program may have never been intended as a particular way to fix the doctor shortage, but currently policymakers in large part view it that way. But this view that GME funding is a major tool in the doctor shortage does not actually play out in the way the formula is designed. The formula is rigid. It's based on legacy grandfathering in of large institutions, and has no mechanism for actually adjusting based on patient need and where doctors are needed. Just to step back a little bit to explain the actual way in which this money is given out. There are two different funding streams. There's direct medical education, which is DGME, and indirect medical education. DGME represents about a third of all Medicare GME funding. This is the proportion that you probably think of when you ask the question, what's the point of why would Medicare fund teaching hospitals? It's this portion. And the idea is to cover the direct training costs of what it costs an institution to train residents, whether it's the supervising physician's time, the other things that come with a hospital having to house and use a resident. Any of the time leading up to when they're not exactly ready to treat patients, all of that is accounted in this direct training costs. But it's based on a hospital-specific rate that was set in 1984, in 1980s cost reports that hospitals reported to CMS. This portion of money is actually weighted by specialty. That is, that primary care and OBGYN residents are counted as 1.0 full-time equivalent employees, while other specialties are counted as essentially a half-time equivalent employee. Indirect medical education is the majority of GME. This is 71%, over 2/3 of funding. And this portion of GME is actually paid similar to like a restaurant tip. That is, whenever a teaching hospital has an inpatient discharge, depending on that hospital's resident to bed ratio, and that's the more residents, the less beds, the higher that ratio is. That is exactly the payment works as like a tip on top of that inpatient discharge. And this is where most of the money is coming down. Because large institutions tend to have more residents than they have beds, you'll see that the top 5% of teaching hospitals get an IME add-on of over 33%, whereas the bottom 5%, those with a smaller resident to bed ratio, get less than 0.3% of an IME add-on. So the current indirect medical education system is currently funding large institutions and rewards institutions with large resident to bed ratios. Next, we want to talk about sort of following the money. There's a lot of questions about what happened after Congress capped GME funding in 1997. How has it flown? How has it been driven to other parts of the country? What are the implications? The first thing that we need to acknowledge is that GME funding is heavily concentrated in the Northeast. We went ahead and took essentially the last decade of GME funding given out on a state-by-state basis and averaged it out and found that New York, Massachusetts, and Connecticut, if you just take those three states, they average over 17 times as much GME funding as states like Montana, Wyoming, and Idaho. Now, a large reason for this is simply because there's huge institutions located in these parts of the country. There's a lot of medical schools in New York, in Massachusetts, in Pennsylvania, and Michigan that were essentially legacy institutions that had a large amount of residents that benefit from the current system. But the problem with this current structure is that residents do tend to actually practice where they train. And so as more GME funding has gone to institutions in certain parts of the country, there actually is a positive relationship between actual doctor supply, that is the amount of doctors per capita in each state, and the amount of GME funding in each state, meaning that states like New York, Pennsylvania, Michigan, Massachusetts, Connecticut actually have higher doctor supplies than states like Montana, Wyoming, Idaho, California, even, and Texas. Even when you break this down by region, we're seeing that funding is flowing to high cost, low growth areas. We can look at this simply in the four regions of the United States. The Northeast gets far more GME funding than its population share would indicate. Currently, the Northeast makes up 39% of all the GME funding, despite only having 17% of the US population. In the South, which has 38% of the US population, the South only gets 24% of GME funding. Our goal in this paper is to sort of analyze why is it this way, first of all, and second of all, how do we actually adjust the formula so that we begin to see GME dollars track regional need and track state by state need. So I want to go through a couple of ways, or three primary ways, that the GME formula fails patients. The first is that the formula rewards large urban hospitals at the expense of small and rural hospitals. IME payments, this is the indirect portion, which is essentially like a tip on top of inpatient discharge, rise automatically with size and cost, not training need. This means that essentially, as more expensive procedures are done in inpatient settings, those institutions are seeing larger IME add-on payments. Whereas a smaller institution that may not have super specialty procedures being done or have physicians, residents there who are in higher paid specialties, they're not going to see as much of an IME add-on because they're not offering expensive procedures. This is a distorted incentive in the current system. That is that teaching hospitals that perform more expensive procedures are getting larger payments. What this does is, you see in our second part, it creates a problem with primary care. The formula rewards specialty slots at the expense of primary care slots. IME funding currently, because it's only given out as a tip on an inpatient discharge, it does not actually follow where training actually occurs. A lot of primary care doctors do their training in inpatient settings, sort of working as a hospitalist. But when they practice medicine, they're doing so in an outpatient setting. And even as a resident, they perform a lot of continuity care in outpatient settings. The current formula has no mechanism for actually reimbursing teaching hospitals for the procedures that are done in an outpatient setting. And in particular, this disadvantages primary care. If you're a teaching hospital, you have a much stronger and more robust incentive to bring on more specialty care because you know that a primary care doctor is going to do less expensive procedures in an inpatient setting. And when they go to an outpatient setting, there's no mechanism for actually paying Medicare GME dollars out for the care that those primary care doctors offer in outpatient settings. The third primary way that the formula fails patients is that the 1997 cap on funding has discouraged new programs and new expansions. Like I mentioned, in 1997, Congress essentially froze Medicare funded slots at levels locking in that era's geographic concentration. In 1996, whatever number of residents you had at that time, you cannot now increase that level of those residents and receive additional Medicare funding for it. Ever since 1997, if you wanted to get more funding for every new resident, you would have to fund that yourself, whether it's through benefactors, through state level funding, or just using other revenue that hospitals get to fund those slots. The reality is that large institutions are getting more revenue through other revenue streams and are able to fund slots above their cap, while smaller and even medium-sized institutions are sort of stuck at their 1997 cap. So since the cap was in place, we've seen the concentration of funding in the Northeast and grow relative to funding in the South and West in rural areas that actually need access to doctors. One of the key ways that we see this is specialists outpacing primary care. Ever since 2000, non-primary care resident slots have grown relative to primary care. We've seen a 2.4 times faster growth in specialist positions than primary care. And overall, primary care share of slots has fallen sharply since 1981. So not only can we make the argument that the formula itself creates incentives and disadvantages primary care, we actually see it in the data. Their residency programs are training less primary care doctors, and we believe this is a direct result of the GME formula's incentives. Like I mentioned, the next key part of our argument is that large programs are absorbing the costs of opening new slots and expanding residency programs without Medicare funding in ways that small programs and medium-sized programs are not. The Government Accountability Office in 2018 sort of defined small, medium, and large, and found that 81% of large programs, these are 136 plus residents, are funding slots above the cap, meaning that 81% of the institutions are able to find revenue through other revenue streams in order to create new residency slots, behavior that we want to encourage. Medium-sized institutions, you see a sharp decrease. This is between 15 and 135 residents. Not even half of those residents are able to fund slots above the Medicare caps. And then for small programs, less than 23% or less than 24% of those institutions are able to fund slots above their caps. This means that there are plenty of institutions that are funding slots at their cap that may be ready to expand and be able to add more slots if given more funding, but are unable to do so. Whereas large institutions clearly have the money to do so. The reason this matters is because there's a key question to answer in Medicare GME funding, which is if the dollars are meant to impact the doctor shortage, is the additional funding for a residency program substitutionary? That is, would they have created this residency slot with or without Medicare funding, or is it additive? Is the actual subsidy contributing to more slots? Our argument in this paper is that large institutions, a lot of their funding is could be considered substitutionary. They would have funded slots without this funding because they can get it through other means, whereas small and medium-sized institutions clearly are not able to do so in the same way, and therefore, if given more Medicare support, could potentially create more residency slots in the status quo. Now, I want to pass it off to my colleague David, who's going to walk through exactly how we came together with 4 policy recommendations to get at these questions.
Yeah, thanks so much, Lawson. Really appreciate it. We have 4 main solutions that we're proposing to reform the issues that we see in the current residency funding model. So one is to allow teaching payments for outpatient care. So in having IME funding, not making adjustments just to inpatient care, but also extending it to outpatient care. And that helps fix the disadvantage that rural hospitals face and that primary care residents face. One is to direct funding more specifically towards smaller programs that are better able to grow the amount of training that they do based on the funding. And so the way we do that is by starting to reduce some of the payment per slot above 250 FTEs and then redirecting those dollars to the first 200 FTEs worth of slots. One proposal is to redirect funding from states which have more of a surplus in terms of residency funding compared to the national average, and redirecting more of that funding towards states that have less residency funding compared to the national average in order to better direct training towards where patients live, so that prevents more of the under-resourcing of some of those areas. And then finally, shifting DGME towards primary care by having more of a boost towards the primary care slots as opposed to the non-primary care slots. So now we're going to go through each of those in a little bit more detail. So as mentioned earlier, IME funding, it's the bigger of the 2 GME payment streams. It's about 71% of the total GME payments. And today it's only paid as an add-on to inpatient hospital bills. And if care occurs in the outpatient setting, a teaching hospital does not receive additional IME funding for training residents there. So that really disincentivizes the training of residents in outpatient settings. And also, as care moves outpatient increasingly over time, this is something that actually becomes more distortionary, and it's further disincentivizing that movement from inpatient to outpatient. And what our reform does, it extends the IME adjustment to outpatient payments, and then it makes that budget neutral on an aggregate level so that the total spending is flat. So we reduce the adjustment made to inpatient and increase the adjustment made to outpatient. So overall, that's flat. We see that rural hospitals tend to benefit more because they're disproportionately providing outpatient care. So 70% of rural teaching hospitals gain funding, and about 65% of urban hospitals lose funding, but most hospitals are losing less than 1% of the residency funding. And it's also the case that urban hospitals that have a larger outpatient share see increased funding. So this change, it really removes the financial penalty for training residents in outpatient settings where care is being delivered, and it better matches the funding to how care is being delivered and how residents are being trained. So next, we propose right-sizing the payments by program size. So today, Medicare pays the same rate for a hospital's first resident and its thousandth resident, as long as the hospital is below the residency cap. So that means that money pools at very large established urban programs, while small and mid-sized programs struggle to increase some of their supply because of high fixed residency costs. There's fundamental differences between the larger and the smaller programs in terms of the economies of scale that residents have. And so it can be more profitable for larger hospitals to be doing their own residency funding in the absence of subsidies. So, for example, a fourth-year surgical resident is probably going to be more profitable than a first-year family medicine resident at a smaller institution. So our reform introduces a declining payment rate above 200 resident slots. So every program keeps the full funding on its first 200 slots. And then above that, there's a decrease marginally for each additional slot by a little bit. And those decreased dollars flow to then the first 200 slots of each program. So as a result, the residency funding programs that are in the 101 to 200 slot range gain about 260 million, and programs under 400 slots come out ahead. So even a lot of mid-sized and relatively large residency funding programs are gaining, and it's only the very largest programs that see some reductions in funding as a result because of the economies of scale that they're able to experience. So total funding still rises with program size as well. So no program ever makes more money by shrinking their amount of residency slots. So there aren't perverse incentives to gain the threshold. And the idea is that then this would target the residency slots in a better way, such that while holding the amount of dollars fixed that were provided in subsidies, it would have the potential to increase the supply of residency funding slots. So next, we propose redirecting funding towards shortage states. So this proposal addresses the geographic distribution issue. Residency slots were frozen based on where hospitals were training residents in 1996, and there's been population shifts since then, mostly to the south and west, but slots are still fixed at the 1996 levels. So what this reform does is it benchmarks every state on two measures. It looks at the residents per capita in each state and the physicians per capita in each state. And it shifts funding from states above the national benchmark for those measures towards states below the benchmark. And it weighs each measure at 50-50. And we don't totally change towards every state being at average. There are potentially some reasons that it would make sense for there to be discrepancies where certain states receive more funding than their population. But we model a partial correction to this, equivalent to closing 25% of each state's shortage gap, so leaving 75% of that in place. And that step moves funding equivalent to about 9,480 residency slots. So in doing that, the states that gain are mostly in the Mountain West, the South, and the Great Plains, which are the regions that have the worst shortages. And then we also model this in such a way and propose a policy in such a way that there are guardrails such that if a hospital is in an underserved region in a state that has a surplus, they're not penalized for that. and it's specifically only the surplus regions within surplus states that get some cuts relative to their status quo funding levels. So finally, we propose reweighing DGME towards primary care. So Medicare's payment formula currently provides more DGME funding to non-primary care residents than to primary care residents, even though there's large shortages in primary care. And residency funding is one of our main mechanisms for reversing that shortage. So there's already a small primary care differential in statute for DGME funding. It's just relatively weak, and so it's not doing as much. And so our reform would widen that differential to 30% of DGME funding. So under our proposal, primary care would out-earn non-primary care by $400 million, so leaving total spending unchanged, but there now being more residency funding for primary care compared to non-primary care. And so that swing would incentivize hospitals to open more primary care slots over non-primary care slots. It's worth noting this change would touch DGME specifically because that's where there's the specialty component of the funding. And that's the smaller payment stream with only about 29% of GME dollars. So this policy could be viewed as a targeted complement to some of the other structural reforms that we've discussed before that would impact IME more. And it's also worth noting that there's internal medicine residents that are included in the definition of primary care for these purposes of DGME funding. And a well-drafted version of a proposal could preferentially target family medicine and general pediatrics, which are likelier to be providing primary care, rather than exclusively using the current broad statutory definition, although there could still be a component that would be using that broad statutory definition. So now there are 4 more reforms that we didn't formally model, but could be a helpful part of a serious GME package. One is closing the dual classification loophole for hospitals. So there are ways by which urban hospitals can legally classify as rural for Medicare payment purposes while operating in major cities. And the result is that most of the rural GME money is flowing to large urban hospitals. So even when Congress targets rural training, it's not able to target it as well. And it's true that these large urban hospitals are providing some rural training, but the high IME funding levels that they're receiving are not tied to the amount of rural training that hospitals are providing. So every rural targeted reform we showed today, it would depend on how rural was being defined. And so a solution could be to require for IME purposes where IME is not tied to the level of rural training, that be tied to geographic rurality specifically. Another proposal would be to front load funding for new programs. So Medicare GME money is only going to programs once they actually have residents, but there's upfront costs that are required for launching a program. There's years of prior spending on accreditation and faculty. And it's challenging for smaller hospitals to provide that upfront capital before getting the residency funding from Medicare. So allowing some of the GME payments to start during that development window for smaller hospitals could prevent that barrier and help increase the supply of residents and do that in a more targeted way. There's also an issue with preemptive caps, where if a hospital hosts even a few residents rotating through from another program, Medicare can treat that as its training history and permanently set its cap near 0. And that really prevents hospitals from building out a real residency program. And that practice also can disincentivize rotations, which also further diminishes supply. So caps should be set specifically based on when a hospital is setting its own program and not based on this preemptive cap. And finally, it's possible to direct CMS to use CMMI authority to run a GME payment demonstration. The Innovation Center already has statutory authority to test Medicare payment changes, but the efficacy of GME spending, which is over $21 billion a year, has not been evaluated. And as we've been discussing, there are potentially several aspects of it which have been not as well targeted. So a demonstration could take some subset of the reforms that we modeled, such as the outpatient IME adjustment and the primary care differential, and then run a time-bound demonstration. And that could show the behavioral response of hospitals to GME funding prior to making more permanent changes. So really appreciate everyone listening and would love to hear everyone's questions.
Thank you so much, David and Lawson. We're going to turn it over now to the question section. I believe we can put all of our questions into the chat first. Max, you can correct me if I'm mistaken, but you can now do that. If anyone has any questions, feel free to put them in the chat.
Yeah, and while folks are thinking through their questions, first of all, thank you, David, for that. Just wanted to kind of bring up two things related to this process. The first is, I think some of you may be thinking, why do we need to reform GME at all to increase residency slots? And I think there's sort of like a core unspoken part of this that's important to note, which is that the US has a pretty significant residency bottleneck right now. Over 9,000 folks in the US who graduated with an MD last year did not actually match to a residency program when the match program sort of tried to match all of the MDs to residency slots, meaning that we're currently short over, and we expect it to be even more soon, short over 10,000 residency slots for the amount of MDs that we're actually generating in both foreign and domestic medical schools. So a lot of states have recognized this problem and they want to keep their MDs in the state. But the problem is, as David noted, there's a lot of states, particularly in the West and Southwest, in the South, that don't necessarily have the capacity or the infrastructure needed to keep residents there, which is why a lot of doctors are then doing their MD in other parts of the country and then moving to the Northeast for residency and then planting roots there. And so our goal in this is to figure out how do we ensure that the physician shortage, which is largely a distribution problem, in addition to being a simple total numbers game, how do we fix those distribution challenges so that the GME dollars are actually a lever to direct doctors to where they're needed and where patients are actually living. So that's our primary goal. We found, and this is my second point, we found that there are sort of two camps on this oftentimes. One is a camp that simply believes that hospitals don't need these dollars, and therefore this is a way that which we should try to save federal government's spending. At Niskanen, we believe that there are a lot of hospitals that potentially do not need this level of subsidy in order to fund residency slots. However, we view this as an opportunity. That is, that there's a $20 billion pot of money that's given out every year that is simply not at all targeted or harnessed to address the physician shortage. And we should be using these dollars to do so. And so our goal here is simply to provide modest ways to adjust that to ensure that folks are actually benefiting from the pot of money. I think there's a second camp that essentially argues that we just need to uncap and then add more slots. The problem is that our research and others as well have shown that the actual formula itself is broken and not at all targeted to need. And it's important to fix the foundational formula before we add more revenue to this program. And so our take is essentially that there is a residency bottleneck. We need more residency slots, but the best way to do that now is to fix the formula rather than to simply add on more slots on top of the broken formula that we see. So I'm going to go ahead and go through some of our questions. The first one we have is if GME dollars are redistributed toward lower cost states outside the Northeast, how much further would those dollars go? That's a great question. David, you may have some thoughts here, but I can start out. Essentially, one of the key arguments in this piece is that there are a lot of states that would be able to train more doctors with the dollars that are given to states in high cost areas like New York. It costs almost double in New York what it costs to train a resident as it does in Georgia. And so one of the key ways in which we think this reform can be beneficial that we didn't exactly model is that there are certainly states that would be able to produce a lot more slots with the exact same amount of money that potentially is going to a state in the Northeast or in an urban or slots in urban areas that have high cost of living. And so there are a lot of opportunities in addition to the actual distribution benefits, I think there may be additional benefits by way of potentially even more slots generated due to that transition. David, do you have any thoughts on that?
No, I think you covered that pretty well.
Okay. Another question we have here is, would this same reform benefit the psychiatric or mental health care? Yeah, so psychiatrists would be lumped into this exact same bucket of money. And there are definitely some statutory definitions, David, correct me if I'm wrong, that would include psychiatry as primary care.
Yeah, I believe so.
Yeah, so we definitely view psychiatry and the psychiatric shortage as on par and with similar, we're seeing acute shortages in both psychiatry and primary care. And so all of our reforms that are aimed at getting more doctors to primary care, I think there's definitely an added benefit for psychiatry as well. Another question we just got coming in, would extending IME to outpatient settings meaningfully increase primary care residency training, or would hospitals still have stronger incentives to expand higher margin specialties? I think there's a couple ways I would target or I would confront this. One is that certainly, yes, hospitals will always have, in some ways, a stronger financial incentive to expand higher margin specialties, separate from Medicare GME payments, just simply based on revenue generation. However, our goal is to simply cut into that incentive in the best way we can. I think that when we actually include the outpatient payment system in IME's add-on, that would significantly impact the behavior of teaching hospitals and the incentives that they currently have, because they would want to capture that funding, and therefore they would want to make sure they have residents that are performing care in outpatient settings. Do you have anything to add to that, David?
Yeah, I would say there's obviously parts of the incentives of pushing people towards specialization that are outside of residency funding itself, but the residency funding does play a large role. And to some of the points we were making before, the fact that hospitals are still going to have strong financial incentives to expand high margin specialties, they might have a greater ability to do that without the GME funding or having as much GME funding from Medicare as opposed to primary care residency slots, where the increased funding coming from the GME residency slots and redirecting more towards outpatient could more meaningfully incentivize hospitals to do so, because there isn't as much margin there and there isn't as much incentive in the absence of subsidy to provide some of those slots as compared to some of the higher margin specialties.
One commenter noted kind of a point of clarification, which is that of the over 9,000 those who graduated with an MD last year that didn't match, a lot of them ended up potentially matching through the supplemental match, or what's called the SOAP program. And a lot of times what happens is an MD may have their top 3, 4, 5 choices and then not get any of them, and then end up matching to either a specialty or a program that maybe wasn't necessarily what they wanted. And that's a lot of times where you have specialties that are more likely to be primary care in that process, because there are a lot of programs, unfortunately, throughout the country that actually do not fill all of their family medicine, internal medicine, psychiatry, pediatric residency slots. And one of our, kind of thoughts as we're writing this paper was, how do we make sure that the programs that actually do fill all of their family medicine slots, fill all of their psychiatry slots, are incentivized to be able to create more because they've demonstrated that they can fill those positions. And so that's one of our hopes with some of the redistribution in our models, particularly towards smaller programs and medium-sized programs and programs in underserved areas that may be successful so far at filling in those slots. How do we make sure that those programs continue to get that benefit? I think that, there's a Senate working group that put together a reform package 2 years ago that actually created an add-on or an earmark for institutions that were already funding slots above their cap. That is essentially a way to reward good behavior in residency positions. And I think the idea on its face may seem logical that we would want to fund programs that are exhibiting good behavior, that are continuing to open up residency slots, that are building the capacity, pouring in the investment. But the reality is, basic economics tells us that we really want the subsidy to be additive, meaning we want it to actually go towards programs and institutions that need it in order to produce doctors. And in this way, ensuring that dollars actually go to the institutions at their cap or even below their cap, that have clearly demonstrated or want to be able to expand. We want to make sure that the program is set up in such a way that those who want to expand but can't without the needed capital investment, that Medicare GME is actually a tool to enable that expansion. One other question we just got. Some residency programs don't train the full complement of residents they are funded to under their caps. Can you speak to that and what reforms can also incentivize full utilization? I guess I sort of answered that a little bit, which is that the programs that are actually, funding at their cap that clearly are funding basically just as many slots as Medicare will fund them to create. I think David mentioned this towards the end, which is, there's a lot of capital investment and upfront costs that come with creating a program. And there are very simple, even small reforms that can make that easier. I've received several emails since we wrote this paper from teaching program directors in institutions, universities in the South, particularly in Texas and the Southwest, who, like David mentioned, may have had rotating clinicians, residents back in the day, and those residents counted towards their Medicare cap, which essentially put a ceiling on what they were able to get from Medicare when they create a new residency program, which is unfortunate because it seems that there are several institutions that want to create new residency programs that simply cannot because they are essentially preempted by having a high cap that essentially is never reflective of what they're actually doing and what they actually were training. So I think there's small reforms that we can make sure that we incentivize those institutions that are either at their cap or were accidentally capped back in the day. One other question we just got, since the current reform GME formula appears to reward specialty training, would these reforms mostly change the types of residency slots hospitals offer, or could they also meaningfully influence more physicians to choose and remain in primary care? David, do you have any particular thoughts on that?
Yeah, I mean, I would say that to the extent that there are more primary care slots that are being provided on the margin, that ends up increasing the supply of primary care. I think that's also where it's worth noting that caveat in terms of internal medicine and the targeting of some of these slots, where uh, there can be changes that maybe are going to reward the statutory broad definition of primary care, and then there can be lots of subspecialization from there. And so one way to get a higher supply of primary care and diminish how much there's a reward of specialty training over primary care would be to have a more targeted definition for at least the component of that spending, where family medicine and general pediatrics was more what was targeted over the internal medicine slots.
Yeah, no, 100%. And I think, obviously there are a lot of different payment mechanisms and funding streams that impact folks' choices, prospective doctors' choices of what specialty they want to go into. And ultimately, I don't blame any doctor who wants to go into a specialty in order to make sure they can make enough money to cover high student loan debt and other costs. I think the question is how do we ensure that this particular bucket of money is used as a way to improve the incentives of that decision towards primary care? But also Niskanen works on other payment reforms, whether it's actual primary care payments and how they're determined in terms of what will Medicare reimburse for a primary care visit relative to what it would reimburse, for example, a dermatologist for a skin lesion removal, things like that, where you have clear what we would consider value misalignment, that is, the value of primary care to population health versus what we're willing to pay for it. And fixing that and fixing all of the other things, whether it's how long it takes to go into the program, student loan debt, there are a lot of questions that ultimately impact whether or not doctors will choose primary care and whether it's financially viable long term. And then secondarily, in terms of remaining in primary care, a lot of that has to do with burnout and admin burdens. So there's just a lot of different policies that could be done to improve that. This is one particular bucket of money that we think is currently misused that can be improved on the margins there. I don't see any other. Oh, here we go. Would redirecting GME funding toward rural states create durable physician pipelines of rural communities, or is there a risk that residents trained in rural areas will leave after their residency ends? That's a really good question. Like I mentioned in the initial presentation, there's good evidence to suggest that residents like to remain and tend to remain where they did their residency program long term. And that's because people are going into the residency when they're in their late 20s, early 30s. And as a result, that's when a lot of folks are planning routes. And so it tends to be that where you do your residency, it ends up being where you end up living long term. And so directing more residency slots to underserved areas will improve that. But there's obviously the open-ended question of if there isn't good work there, if the quality of life there isn't what someone wants, then obviously they will move. And that's ultimately, I think, a state-by-state decision. I think the goal is to create the slots, and then states can come in and provide the kinds of extra infrastructure needed to ensure that folks will stay in those locations and incentives. I've seen a lot of states try to do situations where if someone stays post-residency, they'll forgive their student loan debt or offer them boosted salaries. And so states are definitely competing to try to keep residents in state. And I think that there's a lot of states that have good ideas there. But this bucket of money is not something that it can be used to do that. I think states individually are probably going to have to do the work there. David, anything to add?
Yeah, I think the only thing that I would mention is that in addition to the state policy, it's true that, maybe like on the margin, there's going to be some physicians that leave the states that they train and go elsewhere, just like now. But now it's really hard to end up with an adequate supply of physicians in those states because there simply aren't slots in those states sufficient to meet the population need. So even if it does end up being the case that some of those physicians that now end up training there do leave, it still should be ending up with a higher supply of physicians than previously.
One other question just came in. Could you talk a little more about the problem of urban hospitals being classified as rural? Why doesn't Niskanen advise closing the loophole completely rather than a reform where we simply ensure that those urban hospitals are, in fact, providing rural training? David, do you want to take that first and then I can add on?
I mean, I'll say there's a broader issue in terms of like the urban rural classification that has been under discussion outside of residency. But I'll just say that here, IME, by nature of how it functions, also it's just not so tied to what care is being provided. That's more the DGME aspect of the training versus IME doesn't really get tied to specific care being provided in the same way. And so it's harder, I think, in that setting of IME to ensure that the urban hospitals are providing rural training commensurate with the additional funding that they're receiving in IME. And so I'd say that's part of the reasoning for that suggestion.
Yeah, and I would add that obviously there's reclassification that hospitals are doing for a variety of different programs or a variety of different revenue streams. I mean, you have the wage index, which is another reason why hospitals will like classify as urban and then reclassify as rural to get the wage to get wage index benefits. And so our intuition is more focused on directly on IME because it's not a stream of funding that is about the kind of care that's given out, and instead is more focused on total volume. That's where we want to make sure that there's no way that those programs can use that loophole at all. I would say this isn't necessarily a recommendation on the other ways in which the dual classification process works in other programs. Without seeing any other questions, just wanted to say briefly that Niskanen Center works with folks. I know there's a lot of folks currently on the call that work on the Hill. We're available and happy to talk through any of these reform ideas after this meeting and kind of help you understand how this plays out in your district or your state. We're excited to work with anyone interested in reform to this program. We think that there is a huge opportunity, and clearly there's momentum growing. In February, the House Ways and Means Committee held a hearing where members of the committee very clearly and witnesses laid out a lot of these arguments that are in our paper, showing that the funding is misaligned and maldistributed. And so, we're excited to see all this momentum and think that we have a real opportunity over the next few years for Congress to actually harness this pool of funding and direct it to where patients are. David, any last words before we end it here?
Just want to thank everyone again for their time and their engagement with this work. And yeah, thank you so much.
Yeah, thank you all for joining, and hopefully we'll see you around soon.